Good afternoon, everyone. I'm Dr. Venice Omona, MD3 Pediatrics. I'm going to take you, on an overview of a bit of the epidemiology, the pathogenesis, the presentation, the diagnosis, and something small on the management of measles. You already had the two cases, and what I'm going to give you is basically what you commonly see when faced with measles. So in the background, we know this is an acute, highly infectious viral disease that was first described in the 7th century. And before vaccination, it had a near universal, infection, meaning it was found almost everywhere. Okay? And it's very common and often very fatal, especially in the developing countries like ours. And of note is that measles is vaccine preventable. And then the virology, the other name is rubella. It's a rubella virus, a member of the paramyxovirus family of the genus Morbillivirus. It has some important proteins, some proteins that, helps in its pathogenesis. And mainly we have hemagglutinin and the fusion proteins, and they are very important surface antigens. And of note also is that measles, there's only one antigenic type. Though there have been cases of mutations in those antigenic proteins, the hemagglutinin, but they have not had any epidemiological significance. Okay? And the other thing about the virus is that it is easily inactivated by sunlight, heat, ether, acidic pH, or trypsin. The occurrence, it's been known to occur throughout the world, like I already said, though because of the advent of vaccines, it's mostly the developing countries which are still, lagging back. And then the reservoir, it's only in the human. There has not been any, secondary or animal, host for measles, and there have been no reported cases of asymptomatic human carriers. The transmission is through the respiratory tract, meaning it's airborne, and every time you have aerosolized droplets from an infected person, you are likely to get that. And in terms of its transmissibility or communicability, 4 days, 2 to 3 days or 4 days before the appearance of the rashes, up to 4 days after the onset of the rashes. So during that period, you always, whoever has it is capable of transmitting it to others. Okay? In Uganda, we don't have much really, but this is from the weekly epidemiological bulletin for week 39 of 2015, and that covered the period of 21st to 27th of September this year. And by that time, in week 38, they had 135, and then week 39, there are 133 suspected cases of measles. And 11 districts reported 5 or more suspected cases of measles during this time. And also notice that we've just had the mass measles vaccination campaign, which was concluded recently in all the districts in the country. Though districts like Wakisa and Kampala had to extend by a few more days. And in this report, Kamwenge district, which is in the Rwenzori sub-region, had the highest number of cases compared to the others. So what really happens with measles? Like we already said, the port of entry is the respiratory tract. Okay? So usually when the viruses land on the respiratory mucosa, there's going to be replication in the nasopharynx and the regional lymph nodes. So after this initial replication and multiplication, you're going to have a primary viremia, meaning these viruses that have been reproduced are going to be shed into the bloodstream. So you're going to have a primary viremia. Now, this primary viremia carries these viruses to the reticuloendothelial systems and then the other regional lymph nodes. And after that, they'll go and replicate again. And from there, there's going to be a secondary viremia. And this is what now sheds it to the other tissues, the liver, the skin, and all the other parts, okay, including the gastrointestinal tracts. Okay. So the primary viremia is 2 to 3 days, usually post-exposure, and then the secondary about 5 to 7 days. Okay? And what really happens in the event that you are infected with measles, what really happens? So like all infections, you're going to have your immune system responding. Okay? And This is supposed to help with the clearance of the virus, help in the clinical recovery, but also in the case of measles to bestow a long-term protective immunity. Okay? And like all the other infections also, we know that the immune system, there is the specific and the non-specific, which is the innate, and then the adaptive, which is more specific. So in the case of measles in the innate, this occurs usually during the prodromal phase of the illness. Okay? And it contributes to the control of the viral replications. And these responses include the activation of the natural killer cells. You have increased production of the antiviral proteins such as the interferon, alpha and gamma. Remember, measles is a viral infection. And then for the adaptive, this consists of both the humoral or the antibody-mediated as well as the cellular immune responses. And in the humoral, you have a production of the measles virus-specific antibodies. Initially, you have immunoglobulin M produced, but later on there's a switch to the IgG subtype, mainly 1 and 4. And then the cellular immune responses, well, okay, before I go there, there's the other thing that you need to know, that whereas the humoral response is important, it's not like what really controls measles infection, because there have been cases of those who have congenital absence of production of antibodies, gamma-globinemic individuals. They get measles, but they have been known to recover fully without any problems. So it's important, but it's not exclusively what is going to help control the infection. The cellular is very important. Measles, like some of the other viruses, also attaches to the CD4 positive T lymphocytes, and this leads to production of some of the cytokines which are used in the immune responses. And then the other thing is that with measles, there's the immunological memory, which is very important, and this was documented over 170 years ago, where they found that those actually who were infected with measles, in the event that there were subsequent outbreaks, they never got infected again. So how do they present? How does measles present? Usually it has stages. We have the incubation, the prodrome, and then there's the exanthem somewhere there, and then there's recovery. So the incubation period is usually 10 to 12 days. Okay? And the prodrome, we have, it occurs 2 to 4 days, usually post-exposure. And during the prodrome, you have a stepwise increase in fever, which can go as high as 40 degrees Celsius. Then they have the classical, the ones they call the 3 C's of measles: cough, there's coryza, and conjunctivitis. And if you remember, in the first presentation, this patient had some of these things, had conjunctivitis, had a cough, and also had a high fever. And then the Koplik spots, which are found usually in the buccal mucosa, they are described as bluish-white lesions with a red base, and usually they are seen opposite the first and the second premolars. Okay? And they are known to be pathognomonic of measles, the Koplik spots. Okay? And then the exanthem, or the rashes, which occur 5 to 6 days usually. And this follows about 2 to 4 days of the prodrome, and exactly about 14 days after the exposure. And usually it begins in the face, and that is what is most important usually, because you're going to be faced with situations where everyone brings their child with a rash, and they'll tell you, I've been told by the neighbor my child has measles. So with measles, the rashes usually starts the hairlines, precisely the back of the ears, and then it follows that and comes to the face. So usually on the first 2 days, you have the rashes, like spotted maculopapular rashes, which are on the face and the upper trunk, around the neck mostly. But by day 3, it spreads almost to the whole body, okay? And this, coalesce, okay? And the disappearance of the rashes is in the same order of appearance, meaning when they begin to disappear, they are going to start from still the places where they appeared first, the face or the hairline, and following that same order. Okay? And then the other thing with the rash is that there are people who are immune suppressed, meaning they are not able to mount sufficient immune responses. So for those people, they are unlikely to present with that, with the typical measles rashes. So you also have to have that at the back of your mind always, okay? And then for the children who are malnourished, it has been known that they sometimes present with, exaggerated, so they can get extreme discoloration of the skin. Okay? So these are the things that you've talked about. The green picture is how the rashes usually appear. Like I said, on the first day, they are discrete lesions really. And by the third day, they are they are confluent. And then those are the coplic spots. They may not be so clear from there, but from here they are. So what are some of the differential diagnoses? One thing for sure is that the typical measles is unlikely to be confused with the other illnesses. If you are to follow, you take a good history of how these presentations are appearing, it's unlikely that you'll confuse it with any other, illness that presents with the rashes, okay? And it's even easier for you to make the diagnosis if you have the coplic spots present. Remember I said they are pathognomonic, okay? And the differential diagnosis basically depends on the stage, okay? The prodrome, where they have non-specific, presentations, they have fever, they have a cough, they have coryza. It could be any other viral upper respiratory tract infections, which, the pneumonia, the influenzas, the parainfluenzas, the rhinoviruses, and the rest, okay? And the stage of exanthem, when they have the rashes, it could be mycoplasma pneumoniae. They tend to present with rashes as well, and sometimes in extreme cases, they present with symptoms of features of Stevens-Johnson syndrome as well. Okay? Then human herpes virus type 6 infection, rubella, which is the closest to measles, though with the rubella, they have a milder symptom, okay, always. And then the progress of the rashes is very rapid. Usually by day 3, they are clearing, unlike measles. Measles by day 3, it's spreading that's when the whole body is almost affected. But with rubella by day 3, they are disappearing. Then scarlet fever, group A, beta hemolytic strep. Those ones, usually when they examine them, you'll find they tend to have suppurative pharyngitis as well. Okay? So that can help you. Okay? And then also the age. And then the other is the toxic shock syndrome, and then it could be a drug eruption. So you need to have that, and every time you're taking the history, you have to try to bring out all those other possibilities. The diagnosis, now, this is where it's most interesting. The diagnosis of measles almost always is based on the clinical and the epidemiological findings. So if you take your good history and they give you the chronology of the rashes and the presence of the 3 C's, the cough, coryza, and conjunctivitis, okay? And it so happened that during that period, there are many other individuals who are having similar things. You can make your diagnosis without going anywhere, okay? However, you can still do what? Lab confirmation, okay? And lab confirmations usually help if you're suspecting an outbreak because you want to confirm it, okay? But also, remember we said there are those, especially who are immune suppressed, they will not present typically. So if you don't do the test, you may not be able to confirm that is actually measles. So you can isolate the virus from the urine, the nasopharynx, and from the nasopharynx, the other thing of importance is that the tissues, the discriminated tissues, when you go and examine under the microscope, you can be able to observe multinucleated giant cells. So even in blood, you can detect the virus, and in the throat. And then also, if you have a significant rise in the measles immunoglobulin, G, by any of these standard serological assays, like the enzyme-linked immunoassays or the hemagglutinin inhibition, you can do what? You can confirm. And then if you have a positive serologic test for IgM to the measles virus, it confirms your diagnosis. But remember, the first step is always clinical. Okay? Complications, these are some of them. Though for today's case, we are going to mainly focus on SSPE, But remember that measles tend to affect very many parts of the body. So you can have it affecting the respiratory tract, and you'll get otitis media, you can get laryngotracheal bronchitis, you can get pneumonias. Okay? And some of these are directly the effects of the virus, but also could be what? Secondary infections because of immune suppression. Okay? Then you can have in the gastrointestinal, they present with diarrhea. You can have ocular complications, conjunctivitis. Neurological, they'll present with encephalitis, could be acute or subacute. And it affects the other organs as well. Like you can have myocarditis, okay, in measles. Okay. And then obviously a lot of time is spent in the hospital, especially in our settings here. Discovered late, they are coming with complications, and this point you have to look after them from the hospital, and death can occur. Briefly about the management, it's essentially supportive, really. And you have to hospitalize all the patients who are presenting with signs of the complications that you have seen there. And you have to give them antibiotics because measles is immune suppressive, first of all, but it also causes tissue destruction, especially the mucosal lining. So you're going to get secondary bacterial infection. So you need to give them antibiotics. And then occasionally you may have to rehydrate them using intravenous fluids. Okay? And then temperature can go as high as 40 degrees. And these children tend to get febrile seizures. So you need to control the temperature using the standard antipyretics. And then antiviral therapy, ribavirin especially, it has been used, but mainly in the adult populations, really. And they have also used it for the management of SSPE. Okay? And I don't think we have it here. Okay? And then vitamin A. Like usually these children, you need to give them vitamin A. There I put supplementation, but part of the treatment really you need to give them. And usually what we do is we give them on day 1, day 2, and day 14. And the dose for those up to 6 months, you give them at 50,000 international units. Those 6 to 11 months, we give them at 100,000 international units. And those over 1 year, we give them at 200. And then there have been cases of post-exposure prophylaxis for some of the susceptible individuals who have been exposed, though that we don't really have much to say about, apart from the vaccines. In some settings, they are given human immunoglobulins as well. And then you need to give them tetracycline eye ointments. Okay? Because of the conjunctivitis, they tend to get secondary bacterial infection. I remember our child here had suppurative discharges from the eyes, and that's secondary infection. Thank you.